Good morning and a warm welcome to Tata Sky Family Health, a platform that brings to you best doctors in the global field to talk about new innovations and practices in medicine. Today, we bring to you Chopra-Narula Dialogues in partnership with IPCA to talk about cholesterol fitness. Why is it so important? How it affects our health and our heart? Our moderator and expert on the show is Dr. H.K. Chopra, Senior Consultant Cardiologist at Medanta Moolchand Heart Institute and the President of the World Wellness Foundation. Our very special guest with Dr. Chopra today is renowned cardiologist Dr. Jagat Narula. Dr. Narula is the Associate Dean for Global Affairs at Mount Sinai Hospital, New York, and the Vice President of the World Heart Federation. Dr. Narula has been doing pioneering work in the area of atherosclerotic plaques, which rupture and cause acute coronary events. Over to Dr. Chopra to take this dialogue forward.
Thank you, Vrishali. It's really a great pleasure and honor indeed to be here on the platform of Tata Sky Fam Health on a very, very special occasion today. And the occasion is Chopra-Narula Dialogue on cholesterol fitness for the first time from India to the world. I am just a moderator, but the real speaker is very well closely known to all of us and very close to our heart is Professor Jagat Narula. You have been just introduced by Vrishali that he is a professor of medicine and director of cardiovascular imaging, Mount Sinai Hospital, New York. It is just a bit of introduction. I know him almost for the last 35 years. And to introduce Jagat Narula is a real Herculean task. It's not easy. I would like to say that he's the icon of the century in cardiology and cardiac imaging in the world. I am really humbled and honored to be with him today on this important issue to discuss on cholesterol fitness. His contribution is just heard from Vrishali in atherosclerosis and vulnerable plaque is known to everybody in the world. His pioneering work is known to everyone. He has been the editor of Jagat and editor of many textbooks in cardiology, innumerable. And he's coming up now as a chief editor in the book on statins and beyond statins in CVD very shortly. I don't know how to describe him, how to introduce him. Jagat Narula is an epitome of elegance in cardiology. He is an apostle and pioneer of innovations in cardiac imaging and cardiology. I am very proud that Jagat Narula is a doctor from India with a difference in the whole world. He is an orator, a teacher of teachers, a researcher, and an editor par excellence. I welcome you, Dr. Jagat Narula, sir. What is the theme of the dialogue today? I'm sure because public and masses are watching us, what are we giving the information to the public about the cholesterol? That's our main theme has to be discussed. Our theme is sixfold. The first is growing younger and living longer with cholesterol fitness. And the second theme is be cholesterol fit and keep away heart attack, brain attack, leg attack, and lung attack. Cholesterol reduction is reduction of heart attack. If you reduce cholesterol by 1%, you can reduce the cholesterol by 2%. If you reduce the cholesterol by 20%, we reduce the heart attack by 40%. I think it's very important. People should know this, how we can prevent heart attacks. We also have a theme of discussing various modalities of prevention so that none of us in India and the world fall victim to so-called abnormal lipid disorders or dyslipidemia at the level of primordial prevention, primary prevention, secondary prevention, and tertiary prevention with the equal focus on all the strategies. Unfortunately, we are focusing only on secondary and tertiary prevention for the time being. We need to work really hard on this. Then we also want have a theme of shifting our awareness from heart illness to heart wellness by cholesterol fitness. That's a very important theme which we thought we'll discuss with Dr. Jagat Narula. And I always say in India and various parts of the world, people have a lot of pot belly, what we call is metabolic syndrome. So we say longer is the waistline, shorter is the lifeline. Choice is ours. I'm sure we'll have a lot of good discussion on this topic, which is very, very interesting. We must tap the potential of preventive cardiology and cholesterol fitness to have a healthy heart. That's the main agenda which we are going to discuss. I think we all know by now that India is the world capital of hypertension, diabetes mellitus, obesity, heart attacks, stroke, and dyslipidemia now. It's a matter of great concern. And I'm sure here we have a world authority to discuss with us. So what is the agenda of our dialogue? The agenda is what we should know about the cholesterol, how to remain cholesterol fit, and what should be the role of cholesterol clinics. Like in the United States, they have lipid clinics. People don't understand in India about the lipid clinics, so we can create cholesterol care clinics. We'd like to have a viewpoint of our learned speaker. And we discuss a little bit on preventive genomics. Recently, Dr. Narula, we have a lot of young individuals in India we see who fall victim to premature heart attacks. And when they are subjected to evaluation, we find all their blood vessels are choked with cholesterol. It's very painful. And they are not only in the coronaries, but also in the brain vessels, also in the mesenteric vessels and peripheral vessels. And they are not aware of, they don't take any precautions. So I think a time has come, we should talk of cholesterol fitness to the masses. Dr. Narula, I think we already heard a very nice dictum from Dr. Dudley White Johnson from USA, San Francisco, who once said that anybody getting a heart attack below the age of 80, it is his or her own fault. After the age of 80, it's God's will. I think the message is very clear. None of us fall victim to a heart attack, and it's possible if you have a program like Cholesterol Fitness today. I'd like to ask Dr. Narula, what are your recommendations for cholesterol check? What should be the age? How do we differentiate in males and females with diabetes, without diabetes, hypertension, without hypertension, obesity, without obesity? And what is cholesterol? I think people have to know what is cholesterol. What are the sources of cholesterol? Where does it come from? And where does it stay? And what are the harmful and beneficial effects of cholesterol, which a common man should know? And what are the types of cholesterol which we all should be aware of so that we don't fall victim to a abnormal lipid disorder? And how cholesterol are responsible to produce heart attack and brain attack and leg attack? And sir, as you're the authority on the vulnerable plaque, we'd like to have your words of wisdom on this issue on vulnerable plaque. Dr. Jagat Narula, sir.
Dr. Chopra Saab, first of all, thank you very much for having me here and such a wonderful and a kind introduction to me. I am honored, privilege is entirely mine, coming from you. And the way you have introduced the topic, I do not even believe that there is nothing else left for us to discuss. The second important thing, I'm truly humbled again, and I'm truly privileged for the honor and grateful to you that you have me here. So you asked me, what is cholesterol? What are the sources of cholesterol? What are the types of cholesterol? Things like that. So we all know cholesterol is a fat-like waxy substance that is extremely important for the development of brain and nervous system when the child is born. It is really essential that we have the so-called bad cholesterol that we always call it as the LDL, that is extremely important for the growth of the nervous system. As the brain and the nerve cells are myelinating, they require cholesterol. It is also required for making the cell membranes. Now, when the cells are dividing, when the child is growing, or even later, all the cells have to divide. They have to continue to reproduce. And almost all the cells of the body, except the heart and the brain cells, they divide all through the life. They require cholesterol because cholesterol is the most important substance or most important component of the cell membranes. Then it is also required for development or the making of various hormones, vitamin D, and things like that. So it's an extremely common element of our body, which we really need. In our blood, it comes from two sources. One is from the foods that we eat, but more importantly, it comes from the liver. The liver makes most of the cholesterol that our body needs. I hope that answers the question. The other important thing that I would like to say here before we go further, that the risk factors for the high cholesterol, as you alluded to high cholesterol so often in your introduction, it includes family history and the modifiable lifestyle choices of diet and exercise. Having high cholesterol does not usually produce any symptoms. And if lifestyle changes are unsuccessful or cholesterol levels are very high, we prescribe lipid lowering agents such as statins. So we can now start the discussion about the cholesterol as you may want.
Dr. Narula, very nicely you mentioned about the various sources of cholesterol like liver, and from outside we get it from the food. What are the types of cholesterol which a common man should know as a good cholesterol or a bad cholesterol? Because everybody's concerned how to enhance the good cholesterol like HDL and how to reduce the bad cholesterol like total cholesterol or triglycerides or LDL. So what are the methods by which in the lifestyle we can help in reduction of the bad cholesterol and increase the good cholesterol? Dr. Narula, sir.
So what is the good cholesterol and what is the bad cholesterol? As we just said, that the bad cholesterol is something what we call as a low density lipoprotein cholesterol or LDL cholesterol. And the good cholesterol is the HDL or the high density lipoprotein cholesterol. And we often and very commonly use them as just as the good cholesterol and the bad cholesterol. The normal levels of the bad cholesterol, or so-called LDL, they have been a sliding target because the early epidemiological studies calculated the values in large middle class population that was at a higher risk of dying from heart disease. And as you remember that the risk factors were first addressed to by the Framingham Heart Study. So the usual cholesterol values of the Framingham Heart Study, which had included the 5,000 people to start with, that particular population was at a higher risk of dying from the heart disease, and their usual cholesterol values, which were averaged, they were taken as the normal values. So that's why I said that it's a debatable point as to what is the ideal or what is the target dose or target level of LDL cholesterol. So we have been arbitrarily setting the upper limit up to 130. And then those who are at high risk, we say that the upper limit should be 100. And then even higher risk, we set it at 70. Then at a very high risk, now we have started calling it as 50 or 55. However, the fact remains that we are born with 25 to 30 milligram percent of the LDL cholesterol, and rest you could decide for yourself. There are very good drugs which are available to reduce LDL cholesterol, and it is now even possible to bring it under 30 if we need it so. Then the good cholesterol or the HDL. So naturally, higher levels of good cholesterol is an asset. It is normally above 40 and up to about 90. That shows an inversely proportional relationship with the heart disease. But in my practice, I bother less about it if I can bring LDL really low. Exercise increases it effectively, so exercise is the best way to go. Moderately intense exercise is important. And it also brings down the triglycerides, and triglycerides also, they go almost inversely proportionally to the HDL levels. Reduction in sugar consumption helps. There is no medicine or there is no good medicine to increase the good cholesterol, and the focus must remain on the reduction of the bad cholesterol and the triglycerides.
A very nice message by Dr. Jagat Narula. I think everyone should know that our focus should be reducing the bad cholesterol. It was very nicely pointed out by Dr. Narula that the targets of LDL are significantly variable and beautifully expressed. It can be 100 when there is very low risk. It can be 70 when it's a moderate risk, and can be 35 or 40 or even 50 when they got a very high risk. So I think we have to individualize our patient depending on the risk they have. It's a very, very important message. The target of bad cholesterol, especially LDL, should be known to each and every one, not only in India, but in the whole world. I just like to ask, Dr. Narula, it's a very common question which is asked by the people, that the sedentary lifestyle, people who don't exercise, are they vulnerable to have a high cholesterol? And what is the relationship with the smoking? What is the relationship with the alcohol? People who consume more than 2 or 3 packs of alcohol, do they get high triglycerides or high bad cholesterol? We'd like to have your opinion, sir.
So, if we are talking about the cholesterol levels in relationship with, say, obesity, smoking, alcohol, stress, aging, I mean, all these factors. So, I would say that smoking, alcohol, and stress, if we take them all together, all of them increase the cortisol levels, the stress hormones, as well as the adrenergic state. And hence, they cause a surge in the circulating free fatty acids and increase in the bad cholesterol, triglycerides, and it also lowers the good cholesterol. A modest alcohol consumption could raise good cholesterol levels, as has been widely accepted. But then, what is considered modest is very important. And then there is an opposite effect after the modest level of alcohol, because it can raise both cholesterol, bad cholesterol, as well as the triglyceride level. When we talk about the age, the bad cholesterol concentration increases after the age of 20, progressively, both in men and in women, but more rapidly in men, accounting for most of the overall gender difference. The rate at which the bad cholesterol concentration increases in women begins to accelerate between the ages of 40 and 50 years of age, and the concentration exceeds that in men by the age 55 to 60. Now, when we talk about the obesity, which is now becoming a major problem in all the low and middle income countries, and specifically in India, as you had alluded to in the beginning, being obese means that one is at least 20% over the ideal body weight. If this is you, you are not alone. 80 million of people in the United States, that is more than 1 in 3, suffer from obesity. And as I just said, that in the low and middle income countries, including India, it is becoming a major, major problem. In the Middle East also, as you have seen, that this has become one of the most important problems of the Middle East. It has dire effects on health. It raises the risk of diabetes, stroke, arthritis, and it increases the heart disease, increases the cholesterol. Obesity increases the amount of LDL cholesterol that the liver makes, and it also decreases the clearance of the LDL cholesterol. Changing the diet has little effect of its own if you are obese. Insulin resistance and inflammation. These are the two important things throughout the body, which is common in obesity. Whereas the insulin resistance changes the enzymes needed to handle cholesterol normally, the inflammation decreases the body's response to changes in the dietary fat intake. We all know that losing the weight is often easier said than done, but it is well worth the effort. Losing 5 to 10% of the body weight can improve your LDL cholesterol, triglycerides, and other risk factors for heart disease significantly. It can help insulin sensitization. It can reduce inflammation. And as the weight decreases, the body starts to respond normally to changes in the dietary fat. So it becomes a cycle that you reduce the weight and you better respond to the dietary changes or the dietary modifications or the improvement in the dietary intake, and you could be helped better. So if you look at the various lifestyle things, it is extremely important that we recognize their relationship with cholesterol and how the lifestyle modification can really help. And we can really discuss about what exactly we could do when you feel it would be the appropriate time.
I think it's a very, very important points mentioned by Dr. Jagat Narula. Dr. Narula, sir, I've got one very important question to ask you is, you've done so much of work on vulnerable plaque. ये क्या चीज है प्लाक? प्लाक है क्या? इसका संबंध हमारे हाई कोलेस्ट्रॉल का हमारी जो धमनियां होती हैं, सॉरी फॉर यू टू स्पीक इन इंग्लिश, व्हाट इज द रिलेशनशिप विद द ब्लड वेसल्स? जो हमारी ब्लड वेसल्स हैं वहां पर ये कोलेस्ट्रॉल कैसे जमा होता है, उसका मैकेनिज्म क्या है? अगर हमारा ब्लड कोलेस्ट्रॉल हाई हुआ तो हमारी नाड़ियों में कैसे जमा हो जाता है? एंड व्हाट इज अ वल्नरेबल प्लाक? प्लाक क्यों रप्चर होता है, क्यों बर्स्ट होता है? We like to have your opinion, sir.
Dr. Chopra Saab, as we were just discussing, that if the cholesterol is high, agar cholesterol zyada hai, so it develops as fatty deposits on the vessel walls, and it could be the vessel from any part of the body, as you so elegantly said, that whether these are the brain attacks or leg attacks or heart attacks. So jahan ki bhi artery hogi ya jahan ki bhi dhamani hogi, वहां पे जो है फैट का डेपोजिशन हो रहा है बिकॉज ऑफ एन इंक्रीज इन द कोलेस्टेरॉल. सो कोलेस्टेरॉल के इंक्रीज होने से और बाकी भी जो सारे रिस्क फैक्टर्स हैं जो हार्ट डिजीज के लिए, दे ऑल कॉज एंडोथेलियल डिसफंक्शन, जो कि इनर लेयर धमनी की जो इनर लेयर जो है वेसल की, उनका डिसफंक्शन होता है, एंड दैट पेव्स द वे फॉर द एंट्री ऑफ कोलेस्टेरॉल इनटू द वेसल सो दैट देयर आर द फैटी डिपॉजिट्स. तो ये जो फैट का जो डिपॉजिट हो रहा है उसका जमा होने के लिए पहले एंडोथेलियल डिसफंक्शन होने की जरूरत है, और उसके बाद जो है वो फैट उसके अंदर डिपॉजिट होना शुरू होता है. एंड व्हेन दीज डिपॉजिट्स ग्रो, दे मेक इट डिफिकल्ट फॉर एनफ ब्लड टू फ्लो थ्रू द वेसल्स और थ्रू द आर्टरीज, एंड सच डिपॉजिट्स दे आर कॉल्ड एथेरोस्क्लेरोसिस, as you first started your introduction with. To fight back these deposits. Now, essentially, these deposits are not expected. They are not normal. They are not natural for the body. And probably when the God must have created us, he must not have thought that we will be so incorrigible and we would be eating so indiscriminately, that we would be able to start developing all these lesions. So, since they are not considered normal for our blood vessels, the body sends white blood cells, or so-called the monocytes, which turn into the macrophages. And I don't want to use those technical terms here, but they send the white blood cells into the arterial wall so as to remove the cholesterol from there. Now, the moment they start to engulf these cholesterol, now this is what the white cells do. I mean, you have got the infections, they take away the infection. When there is cholesterol, which is abnormally sitting in your arteries, they would like to take it away. But obviously, when they eat the fat, they also become plumpy. So they become plumpy eating, and then they die eating. And when they die, they increase the inflammation further. And as this fat keeps on getting accumulated in the vessel, the layer on top of it, which is protecting it from bursting it and getting into the lumen, that becomes thinner and thinner because of the inflammation and because of the deposition of this fat. And it is always under the threat of being disrupted or bursting. The moment that happens, this fat gets exposed to the running bloodstream, and the clot is formed there, and that clot prevents the flow of the blood to the heart, and that can result in heart attack or sudden death in these people. And these are the plaques which are very rich in fat, and those which have very thin covering on them. These plaques are called plaques which are vulnerable to rupture or vulnerable to causing or at high risk of causing sudden death or heart attacks. Now, one important thing that I would like to say before I end here is that quite a lot of time you might have heard your doctors telling you that you have a lesion of 90% or 99% and you are sitting on a time bomb. Not necessarily so. It is more important that if you have a lesion which has a lot of fat deposition in it, those are the lesions which are likely to be more vulnerable to causing the events, even if they are not so obstructive as 70, 80, or 90% or more. So plaque vulnerability is an important concept which we must realize that it is the deposition of cholesterol in the arteries, and when they start to become very large deposits, they make us vulnerable to plaque rupture and hence heart attacks and sudden death. And this could sometimes be, or more often, could be the first manifestation of the heart disease in many people. They may not even have a chest pain, and the first episode may be heart attack, chest pain associated with heart attack or sudden death.
I think it's a very important message given by Dr. Jagat-Narula sir. The first important message is use it or lose it. We must use our body all the time, otherwise we are going to lose it. He also mentioned no pain, no gain in life. We have to have a pain of discipline. Then only you become more heavy of longevity. And I think the very important message he has given today is that we are like walking emotional time bombs if you are obese. A very important message. I think we cannot have better message than this. कि अगर हम obese हैं और हम मोटापा है तो we are like emotional time bombs. वो कभी भी burst हो सकता है. People in India are very fond of eating pakoras, samosas, halwas, kachoris, and fast food. What's your message? Is the fast food really injurious to health? Does it really cause obesity? Does it make us more vulnerable when we already have a vulnerable plaque? Dr. Narula sir.
You said it so well, Chopra Saab. And it often happens when I see Indian patients here also. They would all come to you and say, Doctor Saab, मैं तो vegetarian हूँ, मैं तो कोई चीज गलत खाता ही नहीं हूँ. नहीं, पर आप खाते क्या हैं? बस ये vegetarian. So when you start really asking them, samosa becomes one of the most important food that they have. And we always have blamed French fries, but I think we have much worse than French fries here. When we talk about the two most important things which are served in the Indian cuisine, specifically when you happen to get to the Indian restaurants, samosa to start with and gulab jamun to end with. And I often tell them that these are like hand grenades, essentially. Because जहाँ पे fat और carbohydrate दोनों मिलते हैं, that becomes a real toxic combination. And that's why the French fries are so. और उसमें नमक भी जाता है ज़्यादा. And similarly, समोसे में नमक जाता है and गुलाब जामुन में चीनी जा रही है साथ में. So you have flour, and in the flour you have the potatoes, and then you deep fry it. Gulab jamun mein you take the carbohydrates, deep fry it first, and then you throw them into this sugar syrup. There cannot be anything worse than that. So whether you call it obesity or you call it high cholesterol or high triglycerides or whatever, I think each one of them that you ingest, I think you should think 100 times. You could treat yourself once in a week time or once in a month's time कि आज थोड़ा सा एक टुकड़ा खाया तो अच्छा लगा, rather than making them a habit. So I absolutely agree with you that there is a lot that depends upon what we eat and how we change our lifestyle. So अगर अपन lifestyle की बात करना चाहें, so there are a few very important things which we really can talk. And I think I'm twisting the topic slightly here. That what are the important things that we really need to remember here? So मेरे तीन चीजें मैं हमेशा दुनिया को बोलता हूँ जब भी मैं बात करता हूँ. Talk about three important. एक चीज तो आपने शुरू में कहा था कि age up to 80. मैं कहूँगा कि 80 भी क्यों? Why not beyond that? Why should I say that 80, beyond 80, whatever happens is because of it's God's doing? I think we can age better. We can age nicely. We can age safely. So age जो है, although is shown as the most important risk factor for heart disease, or for that matter for any disease, age is the biggest risk factor. But I always say that age is not a risk factor. Age represents the length of exposure to the risk factors. कि अगर आपका कोलेस्टेरॉल ज्यादा है और आप ज्यादा लंबा जीते हैं, तो obviously you are exposed to cholesterol longer, and that's why age becomes a risk factor. So if you control or reverse your risk factors, you prevent the disease. दूसरी चीज जो मैं बोलता हूं कि genetics is important, sure. And हमने लोगों को सुना है कई बार कहते हुए कि मेरे फादर को हार्ट अटैक हुआ, मेरे मदर को हार्ट अटैक हुआ, मैं क्या बचूंगा. So genetics is very important, but you should remember certain things here. First of all, you predominantly inherit risk factors more so than the disease itself. So if you control the risk factors, you control the disease. Then there are some somatic mutations when we are talking about genetics here. There are certain somatic mutations which are very important, and they increase with age. But they are also related to the risk factors. For example, smoking, eating, not exercising, exposure to the air pollution, and things like that. So again, if we reduce the risk factors, likelihood of having the somatic mutations also goes down. And finally, even if you say that you are genetically predisposed, or you have certain genetic traits which directly lead to the vascular disease, the more important is that there is an environmental factors also which really let it go further. And if you prevent these environmental factors or so-called risk factors, you'll prevent the disease. So even if there is genetics which is playing a role, you can control your destiny here. And the third important thing that I talk about is that do not wait for an extreme increase in the solitary risk factor. कि जब मेरा कोलेस्ट्रॉल 200 हो जाएगा या बैड कोलेस्ट्रॉल या 250 हो जाएगा तभी मेरे को डिजीज होगी. It is always a combination of a modest increase in multiple risk factors, which is more important, than having a solitary risk factor, which is significantly high. So, how do we eat? So, very easily, we can enumerate them and make some general principles for the population here that eat heart healthy food. When we talk about fats, reduce the saturated fats, eliminate trans fats, eat the foods which are rich in omega-3 fatty acids. You said about it earlier. Increase soluble fiber, add proteins like whey proteins and all. Reduce sugar. That is extremely important. Then exercising is important. Take a brisk daily walk, maybe during your lunch hour. Ride your bike to work. Play your favorite sport. To stay motivated, consider finding an exercise buddy or joining an exercise group. और हमारे यहाँ तो बहुत होता है इंडिया में कि मेरे दादा भी सैर पे जाया करते थे सुबह अपने ग्रुप के साथ. मेरे फादर भी यही किया करते थे. There's so many things. I mean, like this community life in India is extremely important, and I think we should fully exploit it. Must quit smoking. Within 20 minutes of quitting smoking, your blood pressure and heart rate recover from the cigarette-induced spikes. Within 3 months of quitting, your blood circulation and lung function starts to improve. Within a year of quitting, your risk of heart disease is cut into half of that of a smoker. And the last important thing for the lifestyle modification, which I would suggest, is that you must lose weight. Carrying even a few extra pounds contributes to high cholesterol, and small changes add up. If you drink sugary beverages, switch to tap water. Snack on air-popped popcorns or pretzels, but again, keep track of your calories. If you crave something sweet, try something like sorbets or the candies with little or no fat and artificial sweeteners, quite like the jelly beans or things like that. Look for ways to incorporate more activity in your daily routine, such as try to increase standing activities, such as cooking or doing yard work or things like that. So छोटी-छोटी चीजों की जरूरत है अपनी जिंदगी के अंदर जो हम कर सकते हैं. खाने में, चलने फिरने में, एक्सरसाइज करने में, खड़े रहने में, स्मोकिंग छोड़नी. So ये सब चीजें जो हैं, all these small things add up. But most important thing we must remember is age, genetics. We should try and defeat them, and we should look after all the risk factors. जब आपको डॉक्टर बोलता है आपका कोलेस्ट्रॉल बॉर्डरलाइन है, ब्लड प्रेशर बॉर्डरलाइन है, शुगर भी बॉर्डरलाइन है, you should think that you are heading towards a disaster. So that's the most important message that we need to communicate. Forget about these borderlines. Bring them down. Lower, the better.
I think it was a very nice expression by Dr. Narula. He said, genes are important, but we cannot choose our parents. We can pacify our genes. We can passivate our genes. We can tame our genes by optimizing our lifestyle. I think it's a wonderful expression because we can't make our gene hostile further by our faulty lifestyle. I have one more important question, Dr. Narula, because a lot of patients who have some kind of chest discomfort or minor change in the ECG, and you are a famous imaging guy, they go for CT angio and correlate with the cholesterol levels. What's your message for the relationship of CT, coronary angio, and cholesterol levels? Dr. Narula, sir.
Dr. Chopra Saab, you asked about two important things here, the coronary artery calcium score and the CT angiography. And I would not be guilty of saying this, even though I am biased because I've spent last 20 years of my life in investigating the role of the CT angiography in the detection of the coronary atherosclerosis and the vulnerable plaques. CT angiography happens to be the most important non-invasive tool in our hands for the assessment of the atherosclerosis. Now, can it identify the vulnerable plaques? To quite an extent. It easily can tell us all the characteristics of these lesions or fatty deposition in the coronary arteries, which can be considered vulnerable plaques. Because you can distinctly see the deposition of the fat in these plaques by the CT angiography. You can also see that when the fat deposits in the arteries first expand outwards rather than moving inwards. And there's a lot of fat that can get deposited even before we start to develop the coronary luminal obstruction or coronary artery stenosis. And that is the reason, as I said earlier, then even sometimes when the lumen is not obstructive or not significantly obstructive, we still can have plaque ruptures and can have heart attacks. And these are the people who may not ever have had the chest pains, but in them, it may be the first manifestation of a coronary artery disease in some of these guys. So CT angiography, as I said, is one of the very important tools. When we talk about the coronary calcium scores, the coronary calcium is one of the very easy things to do. It takes a few seconds to do the test. And the premise here is that whenever there is atherosclerosis or whenever the fat is getting deposited and the white cells are dying in that lesions, there is more and more of deposition of calcium. And as you know, that calcium can be very easily seen when we do the X-rays or CTs. We are able to identify them by giving a very low dose of radiation in these people, quite like a few mammograms type of the radiation that we give to the patients. And we are able to identify the presence of the coronary artery calcium. Now, more the coronary artery calcium, more is the vascular involvement. And if the coronary calcium is seen in all the vessels, you know that all your vessels are involved. Now, higher cholesterol is associated with the higher prevalence of the multivessel coronary involvement, as is revealed by the coronary calcium scans. But you would not find a directly proportional relationship between the cholesterol level and the calcium score. I would like to emphasize that high cholesterol could have vascular involvement with zero calcium, especially in the young. And high lipid levels could be associated with dangerous or vulnerable plaques, and sudden death or heart attack, as I said, could become the first manifestation in these people with the coronary artery disease. So CT angiography and coronary calcium both are important tools for the detection of coronary artery disease, and the way the advances in CT technology has occurred, we are now able to do the CT angiograms as well as the coronary calcium scores at extremely low radiation burden, which used to be our problem earlier. And the day is not far when I would like to predict here that CT angiography would become the most important and the first line test to go for the assessment of coronary artery disease.
So it's a very important message by Dr. Narula. You can predict by doing a CT angio, by calcium score, by lipid profile. So in need of cholesterol care clinic is of a paramount importance. We need to have cholesterol care clinic in India. We are totally lacking in cholesterol care clinic in India. I think it's a very important question, Dr. Narula. We see a lot of patients of familial hyperlipidemia, hypercholesteremia, and a lot of obesity in India. But I think we have to use extensively or widely statins, whether they're atorvastatin or rosuvastatin. We'd like to have your viewpoint, especially when a patient has got a familial hyperlipidemia, how early we can start statins, and in the people who are obese, We should not wait till they get coronary syndrome. We should start the statins well in time. I remember my dialogue with Inas from USA. He said we should start statins very early in a young age in Indians. We'd like to have your viewpoint, sir.
So, Dr. Chopra Sahab, you talked about 2 or 3 very important things in this particular question. The first question was about the lipid care clinics. So, as far as the lipid care clinics are concerned, these would be the centers where you can get the specialist help for managing your abnormal lipid levels or the other risk factors which make you susceptible to the heart disease, or even if you have the heart disease already. And I firmly believe that it is very important when we talk about the lipid clinics, but I firmly believe that we must train, and specifically when we are talking about India here, we must train our primary care physicians better in taking care of lipids, blood pressure, diabetes, smoking management, and they must cast a wider net. Greater the population, larger prevalence of the risk factors, lower socio-educational status, and less accessibility to specialized medical centers make it even more important to deliver care at the grassroots and make essential drugs available to all, quite like what you said about Rozua or Atorva or whichever statin it is. And maybe when you were talking about the 7 S's, I was thinking that should I be adding the 8th S also in it, or bringing in the statin in the same. So it is extremely important that we recognize the use of the statins or the lifestyle modification, and they must start at the primary care physician's level. Now, what age is the early enough age? And again, when we look at the US Preventive Services Task Force recommendations, the ages have been talked about are between 40 to 75. But what happens if I've got a person who has got the age of 25 or the age of 30, and what exactly do I do in them? So essentially, when there is familial hypercholesterolemia, obviously, if the patient is even younger, I really need to start looking at them. And at about age of 30, I really want to investigate and see whether do they have anything going on for them. Now, if the level is more than 190, obviously, I would like to start the statins in them, specifically if they have an evidence of vascular involvement. Now, how do you identify the level of vascular involvement here? Carotid ultrasound happens to be one of the most important things that you can do. And the second thing is the coronary artery calcium, but in the younger people, the coronary artery calcium may not be useful. So it becomes a little tricky question here. The other important thing that I always think about is that if a person comes with the hypercholesterolemia, familial hypercholesterolemia, at that time, I always would like to ask a question, when did your dad or mom had a heart attack? And if he comes and tells me that the heart attack occurred at 35, I would like to investigate that person at the age of 25 years and start becoming aggressively, so that presuming that he's going to have the similar event, I would like to start very aggressively. And if I have 10 years, I think I can manage the situation well. So the question only is that earlier than this age, more than 190, I would start and I would treat it because the guidelines allow me to do that. But if it is less than 190, or when there is no familial hypercholesterolemia, at that time it becomes a subjective assessment. And again, asking the family history, which becomes very important. And I would like to become aggressive at least 10 years before their parents or somebody else as the first degree relative had an episode.
Very nice expression, a very practical method. Dr. Narula said that when there is a familial hypercholesterolemia, we have to start early.
if I could ask a question from you here as to what your opinion here would be, that um, when we talk about these primary and secondary prevention, there is often we would divide our patients into secondary prevention and primary prevention based on the incidence of heart attack. That normally, once the event has occurred, everything beyond that is secondary prevention, and everything before that is called primary prevention. I think has the time come when we should change the definition? And again, the CT angiography or the coronary calcium scores or the carotid ultrasounds or whatever way we are able to identify all this, they all become very important. Should our primary prevention start before such things have happened so that we are preventing the risk factors, the so-called primordial uh, prevention? And our secondary prevention should occur once there is a phenotypic evidence of the atherosclerosis. If I'm able to see that on CT angiogram, if I'm able to see it on coronary calcium score, or if I'm able to see that at the carotid ultrasound, even if the event has not occurred, that should be called a secondary prevention. Primary prevention must start much earlier. And as you had earlier said, that it is the womb to tomb type of prevention. And as we have very recently published also, only about 3 or 4 days ago, when the paper was published, this was the paper which we had talked about with the collaboration with Dr. Tom Lucier, who was the editor-in-chief of European Heart Journal, and with Dr. Joseph Hill, who is the editor-in-chief of Circulation. So we had just presented that the person is born with a cholesterol of 25 to 30, and within 3 to 5 years of time, as has been shown by one very elegant study which comes from the Army Hospital from Delhi, as well as the abstract which has been presented by Dr. Salim Yusuf and Sonia Anand from McMaster University, that the levels by 3 to 5 years of the bad cholesterol, they rise up to 130 to 150. We are doing something majorly wrong with our children. And I think our prevention must start on the day the child is born. And in this particular paper, we have tried to hypothesize that it is probably the sugar which is causing the increase in the cholesterol, LDL cholesterol level. And we have also tried to demonstrate that the increase in the sugar causes increase in hyperinsulinemia, the increase in insulin in the blood that causes an increase in PCSK9, which we can discuss about. And this PCSK9 adversely affects the LDL metabolism and causes an increase in the LDL, suggesting thereby that the breast milk or the breastfeeding is one of the important things for the first 6 months to 1 year of life, which we must follow. And we should try and avoid the formulas which carry a lot of table sugar, corn solids, corn syrups, and we should try and avoid the cereals and all which have a significant amount of sugar associated with it. Simple roti, when the child is able to take it, is much better than going after the cereals for that matter.
I think it's a very important message by Dr. Narula that the prevention you start right from the time child is born. Very, very important message. We must have healthy heart initiatives, cholesterol fitness initiatives right from the school age. In every school, we should have a program like this. We should appeal to the government to start this. That's the best way by which we can reduce the rising menace of chronic artery disease. I think message is very clear that cholesterol fitness is the need of the hour right from the childhood. My last question to Dr. Narula is very important. And I'm sure his word of wisdom on this message will carry a lot of meaning. Dr. Narula, you think that we should launch a cholesterol fitness app to enhance the awareness? You think that we must have a lot of digital programs in today's era to enhance the awareness about the cholesterol fitness? and a TV dialogue like this with a luminary or legend like Jagat-Narula, we can disseminate the information about the cholesterol fitness. What are your views, Dr. Narula, sir?
Dr. Chopra Sahab, it's a great idea. I mean, to have a cholesterol app. And for that matter, I would like to even go beyond that. And we should say that all the risk factor management. It's just not simple cholesterol, but we should also be aware about various other important things. We should talk about obesity, we should talk about diabetes, smoking, high blood pressure. And as you can imagine, that the high blood pressure and smoking happen to be the easiest targets to tackle as compared to others. Then the air pollution. I can prevent smoking, but can I really prevent the air pollution also? It's extremely important. And then the lower socio-economic status, or for that matter, the educational status, they are also emerging as the important risk factor, as has been shown by the pure study risk factor reassessment by Dr. Salim Yusuf's group again. So the apps for all of them might be a great idea, and essentially it has been cholesterol has been a problem. It has been a problem for many years, and I think it was once earlier also on the same platform as I had spoken about it, that when we had done the coronary, or for that matter, the vascular calcium studies in various mummies in Egypt, Peru, Alaska, Nevada, Greenland, and various other places, that we have had the access to the mummies with the Horus group, with the help of Dr. Greg Thomas and other investigators here. We found that even in the mummies about 3,500 years ago or 4,000 years ago had an evidence of coronary arterial or for the vascular involvement, and the calcium was deposited. And the question is that at that time there was no fast food. There were people who used to exercise. So why is it that these people were still having the coronary artery disease, or for that matter, vascular involvement? And we soon recognized that these are the people who were the Egyptian elites, for example. They were carried on palanquins. They did not exercise. These were the people who had access to the goat meat 3 times a day. They had the access to all the agricultural products. They used to feast on the various kinds of bird eggs and all. And is it that did they not have everything what we have today as the risk factors? So these people also had similar risk factors, and they suffered from the disease even at that time. You look at the pure study, you go to any country, any continent, you find that the relationship with the cholesterol remains the same. Higher the cholesterol, higher is the likelihood of having a heart attack. And then our studies in the Bolivian jungles, where we went and looked at the Chimane population. These are the people who walk about 15,000 steps to 17,000 steps a day. The pedometers were given to them, the accelerometers were given to them. These are the people who eat once a day. And these are the people who have had their cholesterol levels between 30 to 70 all their life. These are the people whose sugar levels have been less than 80. These are the people whose blood pressure has always been less than, systolic pressure has always been less than 115. And these people have not smoked. They have seen no air pollution. And these people have no coronary artery calcium. Only about 8% of them demonstrated any coronary artery evidence of any coronary artery calcium, unlike the significant about 60 to 80% of the people in various populations across the world. And the fact remains that if the risk factors in this population can almost give them a coronary artery disease less lifestyle, why can we also not have the same? And can we really take care of this coronary artery disease menace by preventing these risk factors, by living better, by having the lifestyle modifications, and living the way we are expected to live rather than the way we have made it out to be?
What is your message, Dr. Narula, for disseminating information by digital media and television dialogue like today, we are doing today.
I think the digital media today is the most important way of getting across to people. And I truly admire your efforts to reach out to the general and the common population. The only suggestion of mine would be, let us go with the smaller bites, small information, because I do not know how many people would be really willing to look at a 1 hour dialogue between two of us, unless we include some of the people who are likely to attract them more.
In last, ladies and gentlemen, to conclude this important dialogue on cholesterol fitness, I have to say only two important points. First, I express my gratitude from my heart to Dr. Narula for spending so much of time to educate masses on cholesterol fitness. And I must give a last message today that cholesterol fitness is the need of the hour. Be cholesterol fit if you want to be away from heart attack, brain attack, leg attack, and lung attack. A time has come. We should act vocally and locally like what we are doing today, and focally and create impact globally with a global authority like Dr. Jagat Narula. I also believe that we must inform and perform as it is happening today, early morning in India and late night in the United States in New York. And we must reform and transform the whole world with cholesterol fitness mantra, a healthy heart. It is possible. From my heart, I am really very grateful to Dr. Jagat Narula for being with us all the time and giving you very, very important messages in a very simple way. He is a scientist of an international repute who works very hard in a very serious manner, but a simplified message will of a great value for each and every Indian.
हेल्थ, फिटनेस और पोषण पर पाए बेस्ट डॉक्टर्स की राय सिर्फ famhealth.in पर, और हमारी YouTube पेज माय फैम हेल्थ पर सब्सक्राइब करना ना भूलें।